So we're going to discuss how to actually evaluate cancer patients. And this is going to be more for the clinical setting. We're going to use colon cancer and follow the NCCN guidelines. And I'll show you guys how to actually utilize and find it in the web. So first of all, we type nccn.org. And then from there on the right upper quadrant, you'll actually see a login. You want to make sure you create an account in this aspect. And once you've logged in, you'll find the word guidelines in the left upper quadrant, followed by treatment by cancer type. We're going to click that one and we're going to proceed with colon cancer. This will now be divided by guidelines, evidence blocks, frameworks, and resources, both for patients and physicians. We're going to take the first one, which is for the physician. And as soon as we open up, we actually have a desktop copy of a PDF of the same thing. And so how do we actually use this? Well, in order to follow this guidelines, this will go through the proper workup and diagnosis so that you can complete the staging process prior to any treatment and determine the adequacy of treatment followed by its surveillance. So the first one is you have a diagnosis, you complete the workup to determine which stage you are, followed by your appropriate treatment per stage of your diagnosis and treatment response through your surveillance. So let's go about it. We're going to proceed to page 9, and this algorithm basically discusses how you diagnose a cancer. And from here, it's usually done through a colonoscopy where a lesion is biopsied or completely excised. And this differentiates it between a completely excised specimen versus a fragmented specimen down here. And from that algorithm, something that's completely excised could be either a pedunculated polyp, a polyp with a stalk, versus a flat polyp, which is a sessile polyp. The difference being is you're more able to get a easier margin if the stalk is negative for malignancy, compared to something that is flat on the wall, wherein you may need more extensive resection to ensure that you do have a negative margin. And from there, you could see the options of either observation for a pedunculated polyp with invasive cancer versus a observation versus a colectomy and block removal of their regional lymph nodes. How do we know and differentiate? Well, there would actually be a guidelines down here wherein you would have favorable histologic features and clear margins. And if you go down and click Principles of Pathologic Review, this will take you to page 26, wherein you will have your histologic features which are favorable and then unfavorable histologic features. I'm not going to go through all of this. You guys can take a look, which mostly includes angiolymphatic or vascular invasion, how close it is from the tumor margin, any electrocardiographic artifacts, and so on and so forth. After you've determined where your specimen is and its adequacy of resection and whether it's a favorable or unfavorable cancer, then you can determine what treatment type you're going to undergo. So we're going to go back up. And so for fragmented specimens, those with unfavorable histology, then you can go proceed with the proper workup. And so it slightly goes through the workup down here, and we'll go to it in detail, followed by the surgery. So what is going to be the workup? Well, the workup is going to be differentiated between people who are resectable and people with unresectable disease. Well, how do we know? Well, you got to understand the workup, which includes laboratories, imaging, and endoscopy. So it is presumed that you underwent a full colonoscopy that there is no other lesions in the colon. And so if you have an isolated lesion there, then you could get your CBC, CEA, and your chemistries prior to any intervention. And why do we need those? Well, number one, your CBC is your baseline. If you have any chronic anemia, you have any thrombocytopenia, leukocytosis, other things that both are risk factors of the disease process, on whether you've been losing blood from the malignancy, any signs of protein calorie malnutrition from a low albumin. These are all things which paint your health as a patient with now newly diagnosed cancer. Why do we need CEA if we already know that you have cancer? Well, the CEA is something that is going to be used for a trend. And so if you have your baseline and now you underwent treatment and undergoing surveillance in the future, you utilize CEA as a trend so that if there is an uptick in your CEA, then it makes you suspicious for the possibility of disease recurrence. And further workup is now entertained in that aspect or continue to monitor it. So what are the other aspects of the workup? So we underwent the laboratories, the endoscopy, and now the imaging. The imaging shows whether you actually have metastatic disease, and that's basically the gist. If you have metastatic disease, or if your disease is locally resectable. If it's invasive, you want to understand if it is resectable still, or if it is metastatic, you still want to understand, even though it is metastatic, certain forms of metastatic diseases are still resectable. And that leads you now to your next treatment after you've undergone that aspect. So, after completion of your workup, you are now appropriately staged so that you can understand what the next treatment phase would be. And so, this is now divided into resectable and unresectable, with obstruction or no obstruction. The obstruction basically shows if there is any urgency. Otherwise, you are going to be on elective case. So with resectable, this is going to be a resection of part of the colon with en bloc removal of the original lymph nodes. If there is an obstruction, then consideration for diversion after resection may be entertained because of the complication of a leak with reconnection. However, if you have a advanced disease, a clinically T4B or bulky nodal disease, then in that aspect, part of the cancer has already gone out of what you're going to resect. And the concern is the increased risk of disease recurrence. And so in this aspect, people get neoadjuvant therapy. What is neoadjuvant therapy? What's the difference between neoadjuvant and adjuvant? For people with high stage cancer, those with high suspicions of end disease, nodal disease, or those with metastatic disease, they get neoadjuvant, meaning before surgery, they get chemotherapy. For people who did not get neoadjuvant, then based on their stage on their disease, it is determined if they're going to have additional chemotherapy after surgery, which is your adjuvant. Lastly, on this aspect, we talk about locally unresectable or medically inoperable disease. This one, we don't do any form of surgery, and this is more of towards control of the disease to limit progression. And this next algorithm mostly talks about the different types of treatment for those with metastatic disease. And so with metastatic disease, some people are still considered resectable if it's going to be a small segment that can be taken out with the primary disease, which is the colon cancer. This could be done simultaneously, or you could undergo the colon resection, get adjuvant treatment afterwards, and then determine the response after. So, who are the people who won't get that? Well, if you already have peritoneal carcinomatosis, then an en bloc removal or R0 margin may be more difficult to achieve. What is an R0 margin? Well, there's going to be R0, R1, and R2. An R0 means you have no cancer on your microscopic margins. An R1 is no gross visible cancer on your margins, but you have microscopic cancer on your margins of your resection. An R2 would be a gross positive margin with cancer. And so your primary goal would always be an R0 margin to prevent disease recurrence. In certain cases where palliation is performed, then in that aspect, risk-benefit ratio is considered whether to do an R0 if there is no actual benefit versus preventing injury to other structures wherein we just do an R2 to relieve an obstruction. So after we've talked about the workup, the surgery or intervention, then we talk about the surveillance. So if you got a curative intervention, which includes surgery plus minus adjuvant or neoadjuvant chemotherapy, then we talk about surveillance to determine if there is a recurrence of the disease process. And so the surveillance is broken down into certain pieces. One is going to be a physical examination, which is between 6 to 12 months, and the actual surveillance process is going to be up to 5 years. Followed by your laboratories. Again, we're talking about CEA and monitoring its trend. Followed by an annual colonoscopy. After the surgery, if you had surgery and you had a previous colonoscopy which was complete, then your next colonoscopy would be 1 year after the surgery. If it's clean, then it's going to be 3, then 5. However, if you have an adenomatous lesions, that interval decreases because that's a precancerous lesion. Other things to consider would be imaging to make sure you don't have any disease recurrence, and that is involves your CAT scan of your chest, abdomen, and pelvis. When do we use a PET scan? Well, a PET scan is something that you do consider if you have an increase in your CEA, but you have a negative CT, and now you're worried about disease recurrence. This glucose-based molecule is increased, cancer has an increased uptake on it, and so areas which may be suspicious and not clearly visible on CT may highlight, warranting a biopsy of that area to determine or direct treatment afterwards. So we talked about the diagnosis, the workup, the treatment, and the surveillance. So use these guidelines whenever you guys are evaluating cancer patients, as they are broken down into different types so that you may be up to date in providing guidance and proper treatment for each and every patient that we see with cancer. With that, if you appreciated the video, please click the like and subscribe button. And if you have any comments, questions, or suggestions, please type them below. Thank you very much.